Hello, everybody. I'm Dr. Sarita Rao, Senior Intervention Cardiologist from Apollo Hospital, Indore. And today we are looking at day 3 of the ACC updates from Chicago. The 6 interesting trials which we're going to be looking at today. The first is the interplay of chronic kidney disease and the effect of tirzepatide in heart failure, preserved EF, and obesity, the SUMMIT trial results. The second will be the effect of solbinsiran, a small interfering RNA targeting angiopoietin-like protein 3 on biomarkers of major adverse cardiovascular events in adults with mixed dyslipidemia, a randomized phase 2 trial. The third will be the incidence and the impact of acute valve syndrome before aortic valve replacement, insights from the early TAVR trial. The fourth will be the EXTROM trial. The fifth will be the DECODE CKD trial, which we're looking at. And lastly, we'll also look at the efficacy and safety of AZD0780, which is an oral small molecule PCSK9 inhibitor for the treatment of hypercholesteremia. These would be the results from the phase 2b randomized placebo-controlled clinical trial, the PURSUIT study. Now, when we look at the first trial, that is the SUMMIT, now, we know that obesity leads to both heart failure with a preserved ejection fraction and to chronic kidney disease. Now, the CKD may both influence the clinical course of obesity-related heart failure preserved EF, and incretin-based drugs may actually influence the renal function. Now, this trial had dual objectives. It was to evaluate the influence of the CKD on the clinical response to tirzepatide in patients with obesity-related heart failure preserved EF, and also to investigate the complexity of tirzepatide-related changes in renal function. For both of the objectives, they focused on discrepancies between the creatinine-based and the cystatin C-based estimates of the estimated glomerular filtration rate. Now, the SUMMIT trial randomly assigned 731 patients with heart failure preserved EF and a body mass index of greater than 30 who were enriched for participants with CKD. Now, the patients received either a placebo or a tirzepatide for a median of 104 weeks, and they were followed for cardiovascular death or worsening heart failure events and for changes in the Kansas City Cardiomyopathy Questionnaire clinical summary score after 52 weeks. Because of the confounding produced by obesity and the changes in muscle mass, eGFR was assessed at randomization and then again at 12, 24, and 52 weeks by both creatinine-based and the cystatin C-based formula. Now, what did the results show? It showed that patients with CKD had a greater severity of heart failure, which was reflected by the worst functional class, the scores, and the 6-minute walk distance, higher levels of NT-proBNP and cardiac troponin T, and they had a 2-fold increase in the risk of worsening heart failure events. CKD did not influence the effect of tirzepatide to reduce the relative risk of major adverse heart failure events and to improve the scores, the quality of life, and the functional capacity. But the absolute risk reduction in the primary events was numerically greater in patients with CKD. Now, regarding the renal function assessment, the baseline eGFR cystatin C was consistently 9 lower than the eGFR creatinine, with significant individual variance. Furthermore, the tirzepatide was found to have increased GFR at 52 weeks, assessed by both creatinine-based and cystatin C-based formula, but with considerable discordance in individual patients. Tirzepatide also produced a decline in the eGFR at 12 weeks with eGFR, and it led to an improvement in eGFR at 52 weeks in all patients, but only in patients with CKD. So the conclusion of this trial was the triad of obesity, heart failure preserved EF, and CKD identifies patients with considerable functional improvement and an unfavorable prognosis who nevertheless responded favorably to tirzepatide. Long-term tirzepatide improves the renal function, but the measurement of eGFR in patients with obesity receiving incretin-based drugs is likely to be skewed by the effects of the fat and the muscle mass and by changes in body composition and on the synthesis of both cystatin C and the creatinine. So the second interesting trial was the effect of solbinsiran. Now, this is a small interfering RNA targeting the angiopoietin-like protein 3 on biomarkers of MACE in adults with mixed dyslipidemia. Now, traditionally, the therapeutic target of all current lowering therapies has been the LDL, but the non-HDL-C is an unmet need in therapies. So we're looking at therapies that lower the triglyceride-rich lipoproteins. So typically, the aim of the study was to evaluate if zolbencirin is superior to placebo for the treatment of mixed dyslipidemia in adults, as measured by the placebo-corrected percentage change in ApoB from baseline to day 180. The primary endpoint was CV death or hospitalization for heart failure. The primary endpoint, too, was recurrent hospitalization for heart failure. What did they find? They found that zolbencirin leads to a significant reduction in the triglyceride and the VLDL cholesterol. Again, zolbencirin 400 mg and 800 mg led to significant reductions in the LDL, in the non-HDL cholesterol, and the HDL cholesterol. So the conclusion from this trial was that zolbencirin was well tolerated with a reassuring hepatic safety profile. Zolbencirin treatment 400 mg resulted in durable reductions in the serum angiopoietin-like protein 3 over 270 days, resulting in significant sustained reduction in the ApoB, the triglyceride, the VLDL cholesterol, and the non-HDL cholesterol in adults who have mixed dyslipidemia. These data support further evaluation of angiopoietin protein 3 inhibition with zolbencirin in patients with mixed dyslipidemia at high risk of atherosclerotic cardiovascular disease. The third interesting trial which we're looking at is the incidence and the impact of acute valve syndrome before aortic valve replacement, the insights from the early TAVR trial. Now, typically, this was done to compare outcomes between patients who were undergoing early TAVR and those randomized clinical surveillance who underwent delayed AVR, and also to assess the impact of the clinical presentation at the time of conversion to AVR. About 901 patients were randomized in the intention to treat, and about 455 were in the early TAVR arm, and the other 446 were in the clinical surveillance arm. And at 2 years post-TAVR, again, they were evaluated. The primary endpoint was all-cause death, stroke, or heart failure hospitalization. What did they find? They found that in terms of death, stroke, and heart failure hospitalization, at 24 months, the cumulative event rate is 10.6 for delayed AVR versus only 6.8 for early TAVR, suggesting a lower incidence of adverse outcomes in the early TAVR group. Again, when this evaluation at 24 months was seen, there was a 14.9% in delayed AVR with acute valve syndrome, which was the highest risk, and 8.2% in the delayed AVR with progressive valve syndrome, and 6.8% in the early TAVR, that was the lowest risk. So the conclusion from this trial was that compared with early TAVR, delayed AVR was associated with increased risk of death, stroke, or heart failure hospitalization within 2 years post-procedure. Conversion to a delayed AVR with acute valve syndrome was frequent, representing about 40% of conversion to AVR, and it was associated with worse outcomes, including a composite of death or stroke, primarily driven by increase in stroke rate post-procedure. We come to the next trial, and that is the EXTROM trial. Now, the objective of this trial was to assess if low-dose colchicine at a dose of 0.5 milligram per day will reduce progression of plaque as measured by the serial coronary CT angiography as compared to placebo in patients with stable CAD. Now, typically, the patients were enrolled from the endocrinology and the cardiology clinics, and these were patients who had proven to have atherosclerosis, either on a coronary artery calcium or a CT angio or an invasive angio. And they were given colchicine on one arm and placebo on the other. They had a baseline CT coronary angiogram, and then at 52 weeks follow-up, they had a repeat angiogram. So the primary endpoint which they looked at was the plaque volume changes at 1 year and the hsCRP levels by treatment. And they measured it at 3 months, 6 months, and 1 year. And what they found from this trial was that the low attenuation plaque was not significantly reduced. However, colchicine significantly reduced the total plaque volume progression by 1.1% as compared to placebo at 1 year. There was a 1% difference in the plaque atheroma volume between intervention and the reference arms and was associated with a 25% reduction in the odds of experiencing a maze. Further, colchicine treatment demonstrated trends towards regression of also the non-calcified plaque, the fibrous and the fibrofatty plaque, and significantly slowed the dense calcium progression. The CRP was also significantly reduced by colchicine 0.5 milligram, and the plaque effects were found to be independent of baseline C-reactive protein. Now let's look at this last trial, that is the global effects of cardiovascular risk factors on lifetime estimates. The aim of this trial was to assess treatment effects of dapagliflozin versus placebo on echocardiographic markers of cardiac remodeling. This was an investigator-initiated, single-center, double-blind, placebo-controlled, randomized trial designed to assess the effects of dapagliflozin on cardiac structure and function over a period of 6 months. They looked at the primary outcome of LV mass index and at the eGFR dip at 2 weeks and 6 months, which was associated with the change in the LV mass index. They found in this trial that in patients with CKD, dapagliflozin significantly reduced the LV mass index and to a greater extent than placebo after only 6 months of therapy. The effect on the LV mass index regression was consistent across all clinically important subgroups. There was no effect found on LV systolic function, nor on the LA or LV size. The magnitude of the eGFR dip was directly associated with the magnitude of LV mass index regression. These findings add very important mechanistic insights to the cardioprotective effects of the SGLT2 inhibitors in patients with CKD. And last but not the least, the AZD0780, which is an oral small molecule PCSK9 inhibitor. Now, AZ0780 binds the C-terminal domain of the PCSK9, which does not interfere with the binding between the PCSK9 and the LDL receptor. Now, this works differently than other PCSK9 inhibitors, and it prevents the lysosomal trafficking and degradation of the LDL receptor. It can be taken without regard to food intake. Now, the PURSUIT trial was a global multi-center study at 55 sites in 8 countries, and they compared it with a placebo and with different doses starting from 1, 3, 10, and 30 milligram daily. The primary endpoint that they looked at was the percentage change in the LDL cholesterol from baseline at week 12. The results, again, they looked at the changes in the LDL cholesterol and also looked at the changes in the total cholesterol, the non-HDL, and the apolipoprotein B. AZD0780 demonstrated a robust, dose-dependent, placebo-adjusted reduction in the LDL cholesterol from the baseline to week 12 by up to 50.7%. 84.2% in the AZD0780 30 milligram dose achieved the ACC consensus LDL goal at week 12. This molecule demonstrated a favorable safety and tolerability profile. The PURSUIT study results support further development of AZD0780 in larger studies with a longer duration. Ladies and gentlemen, that's all from the ACC Day 3 at Chicago. Thank you so much.